All right. So hello, everyone, and welcome to this year's very special living room edition of Thursday Evening Series. And today we're joined by the very talented and knowledgeable Melanie Spenceley from the Regional Palliative Consultation Team, and she'll be presenting on a dignified approach to wound care. And before giving the presentation over to Melanie, I just want to go over a couple of quick points. So first, if you have any questions for Melanie during her presentation, please write your questions in the Q&A box at the bottom of your screen. You can also upvote your favorite questions and comment what you think the answers might be if you like. Because we have such a large group for this series, participants won't be able to unmute and they won't be able to turn their videos on. So please direct your questions to that Q&A box at the bottom of your screen. And second, as always, if you want to receive your certificate of attendance for these sessions, you have to complete a brief post-session online evaluation, which I'll email out to all the registrants at least a week after each session. Okay, so over to you then, Melanie. Thanks so much again for being here.
Thanks, Carl, and thank you everybody for being here. This session is a long time in the making, originally planned back in March, and things have been a little bit tumultuous since then, but we're settling in, and I certainly hope everybody's fared well over the spring and summer. So my presentation tonight is going to focus on wound care in our palliative population. And I'm gonna advance my slides. So I do not have any financial disclosures to share with you tonight. I am employed by the Regional Palliative Consultation Team. This program has not received any financial or in-kind support from a for-profit organization. Any products or medications that I talk about in my presentation, I've tried hard to make non-generic references for both medications and products. We would like to acknowledge that the land on which we are gathered is traditional, unceded territory of the Algonquin and Anishinaabe people. The Algonquin peoples have lived on this land since time immemorial. We are grateful to have this opportunity to be present in the territory. This acknowledgement is part of our commitment to working and learning from First Nations, Inuit, and Métis people in our region, so that together we can help plan and coordinate culturally safe palliative care that respects Indigenous rights and preferences. There we go. I'm going to make a couple of disclaimers. This presentation is not intended to provide client-specific advice. Medications that I talk about may be in the context of off-label use. And then this presentation does contain pictures that may be a little bit sensitive for people. At the end of this presentation, I want you guys to walk away with an ability to identify wounds that you may see in our palliative or end-of-life population, evaluate symptoms that are common in our end-of-life and malignant wounds, and apply novel approaches to treatment, and support client-centered care in the context of end-of-life and malignant wounds using tools and frameworks. So just a brief overview. What is a wound? A wound is a breach or breakdown in the skin. Wounds can involve epithelium to bones. Wounds are usually, always a result of injury, and injury arises from a multitude of various insults. So we might have a traumatic injury like a skin tear. We have surgical wounds, pressure ulcers, that's a heel. We have burns, and we have leg ulcers. We also have many other different types of wounds, malignant wounds, diabetic, arterial, venous, amongst others. So the next series of slides is really just intended to give an overview of how to approach wound care. This overview is applicable to both healing and non-healing wounds. So this diagram is produced by Wounds Canada and represents our best practice in wound healing, starting with assessment and following through to evaluation. And then sometimes we have to go back to reassessment. It should be widely accepted that all persons with wounds require fulsome assessment, including environmental and system challenges, quality of life indicators, and using an interdisciplinary approach. Assessment is followed by goal setting, and based on the goals of care, a team may be selected or assembled to implement a plan of care. Outcomes are evaluated at regular intervals, and reassessment of the plan is done based on our outcomes. So Brittany, I'll use this as our first chance to sort of peruse the audience a little bit. And I'll ask you, what kinds of things should we be assessing when we care for persons with wounds? And you can type in the chat, and Brittany's gonna collate those answers, and we'll come back to them. So certainly we want to know the location of a wound. We want to know its history. When did it appear? How has it evolved? What's its appearance? Looking at size, what type of tissue is seen in the bottom of the wound. Are the edges attached? Are they detached? Is it draining, etc.? We're also looking at associated symptoms. Are they present or not? And how burdensome are they? We want to know the meaning of a wound and what does its presence signify to both the clinician and the client. And finally, we need to know the impact of this wound and how it's affecting our patients. And this may take some time and exploration. Brittany, did we get some answers there?
We did. We got lots. Thank you all
Awesome.
for contributing. So we have diabetic control, nutritional status, activity level, blood flow, infection, odor, environment, patient mobility, pressure, circulation, underlying conditions, medications, fluid intake, pain, social, psychological impact, drainage location.
Awesome. Job done. Good job. Thanks, guys. So looking at some assessment tools, these are just a few examples. There's lots and lots of assessment tools out there. Braden is a fairly well-known risk assessment tool. We have Bates Jensen, or the BWAT, which also is fairly popular. And there could be a pressure ulcer scale for healing, the PUSH tool. What's important about these tools or utilizing tools is that they're beneficial for really standardizing measurements and observations, risk factors, etc. And then based on that information, setting goals. More specific to my area of interest is the MWAT. So it's the Malignant Wound Assessment Tool. There's two versions of this tool. There's a research version and a shorter clinical version. The research version is really fulsome. It's really meant to elicit a lot of subjective data from the patients, including not only physical symptoms, but really psychological, social, and self impacts. So the MWAT, yeah, it's really intended for patient reporting. And then the shorter clinical version is really looking and focusing in on symptoms. We also, and this is what I frequently use the most, is the ESAS. And the reason I use it is just simply because of availability. It's the ESAS I know like the back of my hand, and it's available in our chart in the home, and you can download it from Cancer Care Ontario as well. So it's readily available. So the ESAS is a numeric rating system for symptom burdens at a point in time. So at the time of your visit or when the client is filling in the form for you. At the bottom section, so there's a column for others, is usually where I'll slide in some of the more wound-specific symptoms that we're trying to manage. So again, here's our ESAS, which everybody is probably very familiar with. And you can see at the bottom section where it says other problem is where you could maybe include something about wound odor or wound drainage or something very specific that you and the patient have identified together. So goal setting remains imperative, and it is here where we'll maybe differentiate between healable versus non-healable wounds. In the face of multiple comorbidities, sources of injuries that are impossible to remove, or a variety of many other factors, some wounds simply will not heal. Despite this, it is important that goals can be identified for these patients. You might look to your assessment tools to inform your goals initially. So if your patient, for example, rates their wound exudate as having a high impact on their quality of life, your goals might simply reflect a decrease in exudates. Goals can be set using the SMART criteria, making them specific, measurable, attainable, relevant, and timely. So you might discuss with your patient that their goal is that they don't have to change their clothes in the middle of their workday because of wound exudate. You're going to measure this by either they do have to or they don't have to. And it's relevant to the patient's expressed interest, of course, and then setting a time frame to achieve this. And perhaps that's dependent on availability of supplies and ordering certain things that you can try. It may be, depending on your patient and their wound, that the assembly of a team will either be a small team or a big team, depending. A low morbidity wound may not require extensive intervention from multidisciplinary multidisciplines. Certainly, though, if your wound isn't healing, this is something to consider. Particularly if you're not having your sort of what you would expect in terms of percentage of healing, or if the wound is regressing. Certainly there's lots of patients that are going to benefit from this whole approach. When looking at the plan of care for our specific wounds, whether they're palliative or otherwise, we'll start with selection of a cleansing agent. Most commonly, we see normal saline used. It's readily available. It's not too expensive. Normal saline is an isotonic solution. In our community, it comes in sterile packaging, which does provide an element of control when we're using saline for wound cleansing. Wounds are best cleansed using an irrigation method. You know, in the research, optimal PSI would be 4 to 15 pounds per square inch. Too high of a PSI might cause trauma to the wound bed or discomfort, and too little may prevent adequate clearance of wound debris. PSI aside, though, we are also going to consider any discomfort that irrigation might cause our patients. Alternative agents might include tap water. So example would be having your client remove their dressing and shower just prior to your next dressing change. There's sufficient evidence to show that the use of potable tap water does not promote infection when compared to normal saline. Sorry, in fact, also when you can use this shower technique or having the client be able to shower, quality of life scores will improve as well. In some cases, antiseptics might be indicated, particularly for managing biofilms or where there's high bacterial burden. In most instances, we're not going to use antiseptics for long-term use, particularly in our healable wounds. So wound bed preparation comes next, and it really sets the stage for healing in healable wounds. And perhaps in our non-healable wounds, it'll set the stage for symptom management. The TIME acronym can be used to guide this assessment. So you're going to evaluate the tissue. So what is the condition of the tissue in the bed of the wound? Is there tissue debris present that needs to be removed in order to facilitate reepithelialization? Or could tissue be removed in an effort to control odor, perhaps? The I stands for infection and inflammation, both factors which, when present, will produce an increase in unpleasant symptoms and ultimately will inhibit healing. Moisture control needs to be assessed, and the edges of the wound will give us some big clues in the overall condition of the wound. Edges that are detached might give us clues regarding bacterial balance or healability. And in wounds that heal along an expected trajectory, we see that the edges are nicely attached to the wound bed. As mentioned in the previous slide, bacterial imbalance will stall normal healing. Similarly, as we move ahead to discuss non-healable wounds, we'll see that bacterial imbalance will also promote distressing symptoms in these non-healable population. Being able to identify critical colonization, local infection, systemic infection are valuable skills for the clinician. I usually think of critical colonization as the calm before the storm. So when wounds are not healing along an expected trajectory, and that expected trajectory is loosely defined as 20 to 40% wound size reduction in 2 to 4 weeks' time, clinician minds are going to start to identify factors that are stalling that healing. So when thinking of critical colonization, we can use the NERDS acronym. So wounds will be non-healing, there'll be exudates, there's going to be red and perhaps friable tissue in the wound bed, there might be some debris in that wound bed, and there may be a smell. Critical colonization can be managed using topical antimicrobials, and ideally they're incorporated into our primary dressing selection, for example, silver impregnated dressings or condexamer iodines. In deeper infection, we see that pathogenic bacteria will penetrate viable tissue of the wound, and we'll see the host start to mount a response. In addition to our NERDS criteria, we now have our Stones criteria. So we have a size increase, so the wound is going to grow instead of shrink. We have a temperature increase both in the local environment and perhaps a systemic temperature increase. When we can identify os or bone in the wound, so if that wound is probing to bone, we certainly have a problem. There may be new breakdown of the skin, and in this picture example, you can see a little satellite lesion at the 3 o'clock position there. We may have changes, increases in exudate and erythema. Again, that's pretty easily identified in this picture, and our smell. So these mnemonics, like the NERDS and Stones, can help clinicians suss out superficial or even deeper infection. As you tick off more criteria, the sensitivity and specificity for infection increases. Another quick clinician pearl is certainly that if you have an individual whose wound, particularly when we're in the lower extremities, our diabetic foot ulcers are classic for this, these don't tend to cause too much pain because the client has decreased sensation in their foot to begin with. So if those wounds that haven't been hurting for the last 3 months all of a sudden start hurting, I would be fairly suspicious of infection. So so moisture balance, again, a good moisture balance is critical for optimal wound healing. When we have wounds with too much moisture, we will see a delay in wound healing. We'll see maceration of the wound edges, which you can see in this picture here, that sort of white, wrinkly skin. And when wound exudates are exposed to healthy tissue, it can promote pain and discomfort and irritation of the healthy tissue. So of course, finally, with excess wound drainage, we do also promote a hospitable environment for harmful bacteria. So what happens with too little moisture balance? Again, we will have a delay in wound healing. Our wound bed is dry, which prevents the migration of epithelial cells across, and it can prevent autolytic debridement. That would normally take care of some of the debris in the bed. So the role of wound care products may be divided by its intent to add moisture or to manage moisture. In dry wounds, moisture can be added using gels, so hydrogels, and in wounds that are highly exudating, we're going to manage with hydrofibers or alginates. Some wounds may not need any product to assist with the moisture balance. In that case, we'll make a good selection in terms of our secondary dressing to make sure we optimize that environment. And secondary dressings will range in absorptive properties from none at all. So for example, our film dressings to highly absorptive, which would be our foams. And there's a spectrum for everywhere in between there as well. So again, oh, I have a poll, actually, true or false, Brittany? True or false? So I think Brittany may do up a poll for this. Oh yeah, you're good, thank you. So true or false, a reduction in wound size is the sole indicator of a successful wound care plan. I'll give you a minute there to answer that. And are we able to see the poll results?
Yeah, I can share them here.
Thanks.
Okay, I'll end the poll.
Yeah.
Thanks everyone for answering us. Here we go.
Yeah, okay. So I expected that split actually, and I could tell from the first line of questions that you guys would be on top of this. So no, the answer is false. Size is not the only indicator for sure. And particularly, this is true in our non-healable wounds, right? So again, our assessment tools are going to help inform our indicators of success. But we're also going to look at things like, did we reduce the drainage for our gentleman? Is the pain reduced by our dressing selection? Like, these are all wins, right? And all it could be indicators of our successful care plan.
We just had a question come in, Melanie. What are your thoughts on magnet therapy for wound management?
Oh, magnet. Oh, maggot therapy?
Magnet.
Oh, magnet therapy. I have not encountered magnet therapy, to be honest. I thought the question might have been maggot therapy, which I have lots of interesting opinions on, but I'm not familiar with magnet therapy, particularly in the malignant wound population. So I'm sorry I can't answer that specifically.
That's okay. I'm kind of curious about the maggot therapy, but
Oh, it's
I'm
kind of
gonna
neat.
keep going.
Yeah, okay. Okay. Sorry, I just have to close down my screen here. There we go. Okay, so we're gonna now just have a look at a few specific wound types that we're gonna see in our palliative population. More specifically, we're gonna look at some at the Kennedy terminal ulcer, calciphylaxis, and then finally we're going to have a really good look at malignant wounds. Okay, so we'll start with the Kennedy terminal ulcer. These are ulcers that occur in our end-of-life patients, and often their appearance will signify that prognosis is fairly short for these patients, and in the research it sort of indicates death within 2 weeks even. These are thought to be a result of skin failure, whereby we have hypoperfusion as the body is shunting blood away to more vital organs. Also in the milieu of skin failure are metabolic changes and other organ failure as well. So interestingly, these ulcers will be seen in both pediatric right through to our elderly population. So Kennedy terminal ulcers are often associated with what's called the 3 o'clock syndrome, where in the morning assessment, if you're in a facility, you're going to see just a little bit of skin discoloration, and that's going to progress very rapidly through to 3 o'clock where you have a full-blown ulceration. So in the previous slide, you could see that little bit of skin discoloration that was in a coccyx. These ulcers tend to be in the sacral area, but they can come over other bony prominences as well. And they have sort of a characteristic butterfly shape that we've probably all seen before. In terms of symptoms, it will vary, but certainly I would be cognizant of pain related to these wounds, and then as the ulcer deteriorates, they could be prone to odor and exudate. The tricky part of the Kennedy terminal ulcers is that they're really closely related to pressure ulcers. They look like pressure ulcers. The only defining features really being that pressure ulcers in theory maybe are avoidable, whereas Kennedy terminal ulcers are thought to occur regardless of pressure relief strategies. Treatment will almost be identical to pressure injury, and with all of our patients nearing end of life, consideration to pressure reduction and reduction of shearing should be given. Certainly these ulcers would be a diagnosis that would support pain again, so all of our regular supportive care interventions should be in place. If we're able to recognize these as Kennedy terminal ulcers, teaching is important, right? So teaching to the family and to the care providers regarding etiology and, if appropriate, prognosis perhaps.
There was just a question that came in, Melanie. Why a butterfly shape?
I think it's probably just the distribution of vessels and in part where that bony prominence is. Yeah. So when you think about the biology of it, it is skin failure is really that the blood vessels aren't perfusing. So I would say it's probably related to distribution.
Thank you.
Yeah, in this picture here, you can see that discoloration. Again, this is a coccyx. You can see that butterfly shape. And then in the second picture, really a rapid and brutal deterioration. Okay, our next wound that we're going to talk about is calciphylactic wounds. These are a little more rare. Like I've only seen a few of these in the community over my years, but it's an interesting wound if you identify it, right? So calciphylaxis is a type of ischemic wound, and it's often in our end-stage renal disease population. And it starts with a calcification of the vessels that perfuse into the subcutaneous tissues. And then through cascades, we have a full-blown occlusion. So often, again, this is associated with our end-stage renal disease population. And then we also have a subdivision of uremic calciphylaxis. And then in our non-kidney failure population, we have non-uremic calciphylaxis. Often these are seen when folks have a calcium or phosphate derangement. It can be seen in vitamin K deficiency, so looking at our population with using warfarin. Diabetes mellitus is a risk factor, obesity, and female biologic sex. Again, we start with a more benign appearance, so pink plaquing of the skin, which progresses to black eschar. We tend to get some satellite plaques that then will merge into a larger ulceration. Dispersal is bilateral, so that might help you differentiate between a leg ulcer, for example, versus a calciphylaxis that we'll see this bilaterally. And they're also more found on the sites where we have a little more adipose tissue, so abdomen, thighs, and calves. The most prominent feature, and I can't underscore this enough, is these are really painful wounds. And they are prone to infection, and they do have a poor prognosis. So this picture just shows how some of those lesions have merged, and now you have just one giant ulceration, and these are on somebody's thighs. This is a thigh. So some considerations when caring for a client with calciphylactic wounds is that you'll want to be sure from the outset that there is a pain regime in place. Wound care is to minimize trauma and thereby pain, and management of bioburden. Multidisciplinary care will be absolutely essential, particularly in our population who may be on dialysis or those who might wish to pursue dialysis. Involvement with conservative care clinic, perhaps if we're not looking at dialysis, will be valuable, particularly as pain medication management will be necessary. And then we're going to talk a lot about malignant wounds. So malignant wounds have a lot of descriptors. We might see them referred to as tumors, as ulcers, as fungating wounds. They could be masses, nodules, cancerous wounds, skin cancer, metastases. So lots of different words to describe malignant wounds. This definition of malignant wound was adapted from the BC Cancer Agency, and it's infiltration of the skin and its supporting structures by malignant cells as a result of a primary tumor or metastases, either local or distant. And we know that malignant wounds can be ulcerated, they can be cavernous, they can be fistulas, or they can be fungating, which is that outward irregular growth. Most often these wounds are associated with pain, odor, bleeding, exudate, infection, and necrosis. In the bottom left, we have a primary breast cancer with that fungating irregular growth. The top right is a good example of cutaneous metastases. And in the bottom right, we have a colorectal cancer with cutaneous mets. It's not hard to see why these patients struggle with symptom burden. Overall, in developed countries, incidence of primary presentation of malignant wounds has dropped, and this is largely with the introduction of screening programs, for example, the Ontario Breast Screening Program. Although statistics do fluctuate, it's estimated between 5 to 10% of individuals with metastatic cancer diagnosis will have or develop a malignant wound. These wounds are most commonly found in head, neck cancers, breast cancers, and skin cancers. So I'm just going to ask a question to everybody, and if you have cared for someone with a malignant wound, I'm just wanting to know what kind of cancers they were diagnosed with. If you wanted to write in the Q&A.
Yeah, so there's been several that have mentioned breast cancer.
Yeah.
Head and neck, lung, skin cancer, lots of head and neck, uterine, vulvar,
Yeah.
breast, skin melanoma, yeah, skin cancer on the nose, ovarian cancer, renal, skin melanoma.
Okay. So like I think I've had the same experience. I've seen a fairly broad range of different cancers. The gynae cancers are also particularly prone, and some of those vulvar cancers can be quite profound as well. Thank you for sharing, everybody. So when we look at patients who have malignant wounds, we can broadly divide people into two groups, really. So we have a group that will present because of their malignant wound. So they come to the healthcare system with the wound. So this could be a locally advanced cancer or a metastatic cancer. And then we have patients who present with a diagnosis of cancer and go on to develop malignant wounds as their disease progresses. Often when people first present and it's the wound that's bringing them to their healthcare provider, we think, why? What happened? And why didn't we have help for this sooner? And so there was some interesting research done by Dolbu et al., who interviewed individuals with malignant wounds. And there was a really diverse spread of psychological profiles, but some of the emerging characteristics in this small group sample had people who were non-observant of routine breast screening, distrust of the medical system. There was a component of denial or fatalism, confidence in alternative therapy, so people who wanted to try different things before coming to the traditional healthcare system. Depression and anxiety, decreased coping skills. So the coping skill is just to cover up and avoid. So yeah, that sort of gives us an idea of some of the reasons why our patients might not come to us earlier. So in terms of outcomes of malignant wounds, Nielsen et al. Did some research using 75 participants with metastatic cancers who presented with chronic wounds of a minimum size due to cancer growth. So this was growth through the skin or a site of metastases. And they were able to show a relationship between wound outcomes and median survival. So individuals with wounds that did not improve with treatment had fewer days median survival than those with wounds who did show some improvement. So if no improvement in the wound with intervention, our median life expectancy was 134 days, and then median survival with improvement was 387 days. This could be a bit of a commentary on the overall health of our individuals as well when they came into this research program, in terms of ability to heal a wound, in terms of oxygenation, nutrition, and of course, access to care. So again, now we're gonna just segue into how we can manage some of our common symptoms that we see in our malignant wounds. So I've used the HOPE acronym, and I didn't come up with this. This was, I heard this at a presentation by Dr. Nicola McPherson, so I can't take credit for the mnemonic, but we're gonna talk about managing HOPE. So the symptoms that we're gonna talk about tonight are healing, hemorrhage, odor, pain, pruritus, and exudate. And I'm gonna just take a little sip. Okay. So before we get into the symptom management piece, I just wanted to make a small comment on the role of healthcare provider in intervention. So I found this definition of HOPE to be very powerful for both the person who has a malignant wound, who may have the grounds to believe that something good could happen. And it doesn't always have to be that the wound will go away, right? So from the carer perspective, to provide hope, or that we would intend, if possible, to do something for this patient. And I'd ask you just to keep this in mind as we think about the people we care for. So it is important, as with all wounds, to have an idea of the goal for the wound. So are we healing this wound, or are we maintaining this wound? So with healable wounds, we assume that we're going to be able to remove the source of injury. For example, a post-op wound infection, we would treat the infection and expect the wound to heal. In venous ulcers, we correct the stasis using compression, provide an optimal wound environment, and then transition them into a long-term compression garment, right? And we expect that we will get some healing with these wounds. With malignant wound, the offending source is the actual cancer. So if we're unable to remove the cancer, we won't be able to have healing necessarily. With a maintenance wound, we may have the goal in mind just to keep the status quo, right? So we know it's not going to get better, but we're really trying not to have it get worse. And we work really hard to minimize risk of infection or other sequelae. Maintaining a malignant wound may be realistic if your patient is undergoing therapy such as chemo or radiation that might correct the underlying cause, or perhaps those therapies are a precursor to surgical excision. Finally, with palliative wounds, we can expect that the wound will deteriorate or change, and our goal is really going to be to manage the symptoms associated with the wound and the changes that come with it. There are many factors that can influence wound outcomes. For example, chronic infection, poor perfusion, poor nutrition. Certainly in some cases, radiation or chemo or surgical intervention may offer healing, but this might not be an option related to advanced stages of cancer that is associated with so many of our malignant wounds. So this is just an example of the positive impact of chemotherapy on this malignant wound. So this is a case study of Michaela, and she had this wound, and it was really a fear of what this wound meant that led her to late intervention. She did go on, though, to have chemotherapy, and you can see the 18-month interval where she did actually have really decent wound healing there. So I've put these statements in because I think everybody who's helped care for a person with a wound has heard these statements. So I can't wait for this to get healed up, or what can I do to make this heal quicker? And I feel like these really represent typical statements that you hear in your day-to-day dealings. The statements are genuine and they can be taken at face value from your patients, so they're really important to answer. Other times, the patient might be looking for permission to really talk about the meanings of their wound, particularly our malignant wounds, and perhaps what might even lie ahead for them. So like many things in palliative care, these questions can be hard to answer. So in cases like this, I use the wish, worry, wonder framework. And if you haven't heard of the wish, worry, wonder framework, it's well worth looking up. But it goes like this. It says, I wish I could tell you that this wound would heal up for you, but I worry that with the type of cancer you have, this might be part of a new normal. I wonder though, how could we do our best to keep you comfortable with the dressing changes, the pain, or the odor? That's interchangeable, right? So being truthful with your patient doesn't diminish hope, and it can help patients reset and set goals that are achievable within the context that we are working. So again, the wish, worry, wonder framework, using the I wish statement that aligns the patient's hopes, it acknowledges their concerns, and then you have your plan to move forward. Okay, so hemorrhage, certainly this is a pretty important thing to consider when we're working with malignant wounds, particularly head and neck population. There's a few reasons wounds will bleed. Friability of tissue, that is just vessel destruction essentially. Destruction of larger vascular structures, and so this is again dependent on proximity, location of the tumor. And then we can also have bleeding from trauma, so that might come with dressing removal, for example. For small bleeding capillaries, you may see the use of silver nitrate sticks. Silver nitrate's a sclerosing agent, and it's really intended for those small bleeders that can ooze, particularly after dressing removal or cleansing. These sticks will stain the skin a gray color, which usually isn't a huge concern for patients because it will get covered with a dressing. But it's just to note as a caution for if you're evaluating the drainage, the next day you may see some grayish discoloration on the dressing. I've also had people tell me that the silver nitrate stings, and I find that that's mostly in our highly exuding wounds, so that the drainage becomes a bit caustic to the healthy tissues. Tranexamic acid is an oral medication that you may be familiar with. It's an antifibrinolytic, and it's often used in acute care settings preoperatively. In the context of malignant wounds, though, it could be used orally, or it could also be used for topical application. For topical application, tablets can be crushed and compounded into a gel or a cream, or perhaps mixed with a powder for application under dressing. Other times you might see dressings that are soaked with the IV solution, and that could be applied to the wound bed. You need to sometimes, just before using with systemic use, it would be contraindicated with an active thrombosis. But beyond that, the biggest barrier is the cost of the medication. So there may be some coverage for exceptional access, but the application would be required. Similarly, if we're dosing orally, we can set up the timing to really coincide with the pattern of bleeding. So if we get bleeding with every dressing change, we might have the patient take a dose of tranexamic acid prior to that dressing change versus the 3 times a day regime. So just an anecdote regarding timing, we did have a woman on our caseload who had a wound in the base of her mouth and jaw, which tended to bleed only in the morning when she ate breakfast, which was her biggest meal of the day. So she timed her tranexamic acid to be taken in the morning. Then the visit nurses coordinated their dressing changes for the morning, and bleeding was controlled with just that single dose per day, which certainly helped cut down on cost. Sulcrafate is a medication that's commonly used for chemo-induced mucosal infections and treatment of gastric irritation. It also is available in liquid or tablet formulation, and it can be used for topical application in our wounds that are bleeding or prone to bleeding. So again, for tablets, we would rely on a compounding pharmacy to mix either with a gel or a powder, and for that to be applied to the wound and then topped with a dressing. When compared to tranexamic acid, sulcrafate is a much more cost-effective option. So this is just a case study. Mr. J, who has cancer of the salivary gland, has developed an ulcerating malignant wound, and we can see some of that mixed tissue in the wound bed. There's some friable tissue mixed with some sloughy tissue. We can also see some evidence of old bleeding and some little bleeders that are present in the wound bed. So for Mr. J, we would have him consider using an ice pack just over the dressing, and he could apply that for 15-20 minutes prior to the dressing change, which might help decrease bleeding with that dressing change. We could consider filling that crater defect with a tranexamic soap gauze or a compounded tranexamic gel. We could certainly spot treat those little bleeders with some silver nitrate. And then we're gonna top this wound with a dressing that we select that will minimize exudates or control exudates, and also fit in aesthetically, given that this is on his face. Alternately, if the wound was only bleeding around the dressing time, we could consider a dose of oral tranexamic acid prior to the dressing changes. If we're getting bleeding as a result of dressing removal, we're going to look to select dressings that are non-adherent, or at least the first layer is non-adherent. For example, a silicone dressing. We may have some calcium alginates available, which also have some hemostatic qualities. And of course, you're going to top that with absorbent dressing. In terms of timing the care, if you are concerned about the risk of bleeding, you'll want to plan visits for when other people are in the home with you or available on the unit to assist you. And if dressing changes are only taking place every couple of days due to the risk of bleeding, you could coordinate timing of those visits with showering, etc., so that if the dressing became wet, it would be okay. So certainly with many wounds, particularly again, the head and neck origins, that might infiltrate major vessels, we need to be prepared for catastrophic bleeding. This will lead to a dialogue around risk, advanced care planning, and how we can get prepared for a catastrophic bleed. You might want to say to your patient something like, one of the things that I'm concerned about is that there's a risk of bleeding with where your tumor is. In my experience, it helps for us to have a plan that we can review so that we aren't panicked if you were to start bleeding. So often with these tumors, we can see that bleeding will be a slow loss of blood over time, but sometimes it could be a more brisk loss that it's difficult to control. Sometimes this large amount of blood loss will lead to the end of life. So I find that patients seem to know that this is a risk. They will ask if it will hurt, what it might look like for their loved ones. And as they become aware and they know what's coming, we can be a bit more prepared. So the take-home message is really that I want you to inspire confidence in these people because this is heavy stuff, right? So saying to them that we're going to have some medications ready for you that would make you comfortable and not anxious if this were to happen. We have a kit ready and we have a plan in place to use it. And then as a leader of the care plan, we're going to talk to individuals who are coming in and out of the home. They might know what the plan is. You could print it out and put it in the chart or on the fridge so that everybody's really aware of this risk. We will often medicate these bleeds with a fast-acting benzodiazepine. So in our symptom management kits in the community, we use midazolam 5 milligrams, and we can repeat this ×2. And the goal is really to sedate the patient and settle them quickly. Having a kit ready with a stash of dark towels, using dark sheets in the bed, dark pillowcases will also help minimize trauma to the family because we all know a little bit of blood even looks like a lot when it's on your nice bed linens, right? Family will need to know if this is in the community setting, what is the plan, where are the meds, and who to call.
We just had one quick question. What is the dose time frame on tranexamic acid prior to a dressing change?
That's a good question. I would administer an hour before, an hour to half an hour before. Yeah. Okay, our typical tranexamic dosing is 3 times a day. And that would be for somebody who sort of has a continuous bleed, whether it's a uterine bleed or they have a hemoptysis that's ongoing. So I would say if you were just doing a 1 doser prior to dressing changes, I would call them an hour ahead and have them take it. So this will be just another case study. This is Mr. K. And it isn't hard to see why Mr. K is at risk, right? So his initial presentation is with this deep wound that is changing rapidly, and that includes bleeding. This is a case study that was taken out of the Indian Journal of Palliative Care. And in this article, in this case study, he was diagnosed with impending carotid blowout syndrome. Wound care was initiated because, as you can see, there's quite a bit of slough, and he presented with very malodorous drainage. So wound care is set up to help clean up the wound a little bit if possible and have regular wound care. There is a regular dosing of tranexamic acid that was started in this case, pain management, and then the emergency plan, which did include sedation. So that's all there. Yeah, home with the emergency plan. So we'll talk a little bit about odor, and I think anybody who has worked with a patient who has a malignant wound, you know that smell and that odor. It stays with you. It's pungent, right? So odor ranks really high as one of the most burdensome symptoms that's associated with malignant wounds. It contributes to feelings of shame, isolation, worthlessness, and poor quality of life. Odor is a result of bacteria that tends to thrive in this pro-inflammatory and necrotic environment. Anaerobic bacteria emit most notably putrescine and cadaverine, which give us these foul, distinctly foul odors. And this is the odor that you smell and that you do not forget. Fortunately for our patients, they do, or they may desensitize to that odor over time, and this is a protective mechanism. In order to control odor, we often will use metronidazole. This is an antibiotic that is available in capsule, injectable solution, and also available in a gel formulation. In the case of malignant wounds, metronidazole is most commonly used as a topical agent. There really is sparse evidence for its use in the research, but anecdotally, folks generally report decreased odor with its use. So if a patient is responding to a trial of topical metronidazole, certainly it could be tried systemically as well. In the old days, we used to open up the capsules and sprinkle the powder directly to the wound bed, which did actually work quite well because these wounds tend to be moist. But because metronidazole is a respiratory irritant, care providers really, I would really caution care providers in doing this in order to protect themselves and the patient from inhalation. That said, Metrogel is readily available. The 1% gel is a general benefit with ODB, so it can be cost effective as well.
There was just one more quick question.
Yeah.
Someone asked, are these rare cases, or have you cared for many as severe as the past series of photos?
Yeah, good question. So I'm just going to back up a little bit. This to me is not a rare case. So I have seen quite a few at this level, and I know there's quite a few even currently in our community being cared for by community nurses at this level of severity. I have not seen this severity. And I think going back to when we talk about prevalence of malignant wounds here in Ottawa, or even applicable to maybe even our province or southern part of our province, I think this is because we have a little bit easier access to care. So this gentleman, this was in India, and I can't speak to really the environmental or systemic barriers that he faced, but for us, I would say that this is part and parcel for what we're seeing in the community, yes. But that previous head and neck, no, I have not seen one to that level.
Thank you.
You're welcome. Thanks for the question. So again, we're gonna still talk about odor, knowing that the source of odor tends to lie in bacterial burden. Both silver and honey dressings could be utilized for their topical antimicrobial effect. Head-to-head, honey and silver come out equal. So dressing selection will depend more on availability of the product, the type of exudates that are present for the person, and ease of use. These dressings would require secondary dressing on top. So the top dressing is it's a fiber dressing that's silver impregnated, so it's meant to really soak up exudates. But you would have a foam topper likely on top of that for highly draining wounds. The silver dressings are a little bit newer, and they're again meant to decrease the bioburden that contributes to odor, but they can be a little cumbersome to use. So in terms of some other ways that we might manage odor, we can look to good wound bed preparation to help decrease the burden of necrotic tissue and the bacteria that loves that tissue so much. We'll commonly see autolytic debridement, which uses the body's own enzymes and moisture to break down the necrotic tissue, or enzymatic debridement, where we add a product with enzymes in it to break down tissues. Sharp debridement and even mechanical debridement, where we look to remove the necrotic tissue either by instruments, so scissors, or like cutting it out, or letting a dressing dry and then removing it, taking the tissue with it. These would be risky endeavors in wounds that are prone to bleeding already. Dressing selection that might assist with odor control could include charcoal dressings, occlusive dressings, pouching of the wound, and certainly clinicians will need to look at the frequency of dressing changes in order to help manage wound odor. There's lots of wives' tales out there about things that might also help with odor management. Cat litter is a common one, where you would put like a tray of cat litter under the bed, for example, or in the closet or somewhere subtle, right? I've also heard of putting shaving cream in a tray in a similar way. And then once that shaving cream is dry and hard, you would change it up. I've heard of roasting coffee beans in the oven at a low temperature just to help deodorize the air. There are air sponges that are fairly widely available, where you just twist the cap off and set it down. I had a hospice, I had a patient who had a hospice volunteer who very generously would pick up air sponges for the patient each time she went to Dollarama. So that was a cost-effective choice for her as well. I think a big thing that we can do if we're providing care in the patient's home is that we can bag up the old dressing that we have removed, the supplies that we've used, and take it out to the garage or to the garbage can just to remove it out of the proximity. If they're in an apartment, you could ditch that bag in the laundry chute on the way out. I'm curious for people if they would take a minute to write if they have any tips or tricks that they've used to help manage odor in their patients, or yeah, in the community or otherwise.
While people are answering that, we did have a question. I've had people refuse care due to the odor. Do you have any suggestions on how to address this?
So the person who has the wound is refusing care because of the odor?
Yes.
Oh, that's tough. And actually, I've heard of that too. To be honest, I think there's a client that I'm thinking of right now who is in our community who's struggling. I think part of it.
Sorry, there was clarification, Melanie.
Oh, okay.
Healthcare providers didn't want to.
Yeah.
Sorry.
Oh, I was hoping it wasn't that in some ways. I mean, and while I can understand in some ways, that breaks my heart a little bit as well for the patient, because imagine how bad it is for them 24/7, right? How to address it? There's maybe a little smart part of me that says maybe that person isn't the right person to be managing or to be caring for a person with a malignant wound. And maybe they have the wherewithal to know that themselves, to remove themselves from the situation. I also think that part of our obligation, though, as healthcare providers, and when we're really looking at providing dignified care, is perhaps educating ourselves. Like, this is not a hygiene problem. This is not a dirty house problem. That's the odor. This is a bacterial problem, and it's a milieu that is arising from a cancer, which is devastating in and of itself, right? So I don't think I have the perfect answer, except that really just reinforcing that odor is probably one of the most common problems with malignant wounds, and one of the most challenging problems. And that a patient really is certainly worthy of care regardless of the odor of their wound. And I think we all know that. This is an imperfect answer, I realize, so I'm sorry.
But someone said very, very well stated on your response. So
it's hard, right? Like I mean, I am so pro community, or I always say community provider. I'm pro nursing everywhere, I'll tell you, any environment, but it's tough. That's just all I'll say. But imagine, I just sort of think, imagine how tough it is for that patient and their family. And we'll probably talk a little bit about this more later. And yeah, sorry.
we had a lot of people make responses to your question.
Okay, I would love to hear some of them. This is where the best learning takes place.
Some said cat litter, charcoal, camphora. Some said they took an orange and put whole cloves in the skin of an orange.
Yeah. Yep.
Others placed coffee grounds in a coffee filter bag and then placed them in the air vents. Volcanic rock deodorizer bags from Lee Valley Tools.
Okay.
Others said vanilla in the microwave. A jar of baking soda with a few drops of essential oils. Someone said Vicks in the mask works well. Some used air fresheners in rooms of patients. Yeah. Someone said 1 cup water, 1 cup vinegar, 1 teaspoon vanilla extract, 1 teaspoon cloves, and 1 cinnamon stick. It's the recipe.
Oh, that's interesting. Okay. It's well, right now we're wearing masks, right? So you could probably, as long as you're masking outside of the home, is what I would say. Like if you're going to use the Vicks under the nose, just make sure you're masking in the car or outside of the patient's room before going in and doing that. I was gonna say that when my dog got sprayed by a skunk, which was good times, we boiled vinegar on the stove, because I had Googled it, of course, and so boiling vinegar on the stove, I don't think it helped, but we also did the coffee we put our coffee beans in the oven. So thanks, guys. I appreciate your input and your tips and tricks. So this will be just a little case study on our 72-year-old patient who has an evolving wound with fungating characteristics, almost certainly neoplastic. She is housebound and isolated, so not only will she not leave the house, but she also doesn't want people to come. And when she does present for care, her main concern is with the odor of her wound. She's been dressing the wound herself. She's been cleaning it with peroxide and using handkerchiefs, which she changes out and washes in between changes. So with our woman, our plan was to introduce visit nursing in the community to assist with her care, and luckily she was agreeable to having a nursing team visit her in the home. You can see the wound here is actually fairly dry, but was covered with a mixed kind of sloughy material. And because the odor was the most bothersome part, we did opt for using some Metrogel, which is metronidazole gel. It's readily available. And initially we topped it with a hydrocolloid dressing, which made it fairly moist, but this helped promote some autolytic debridement. So we had an outer layer on top of that, which included some charcoal and an ABD pad that she could change at her discretion between nursing visits. So this was held in place with a to-be-fixed bra that was fashioned, and the nurses were agreeable to taking out the garbage with them and placing it in the outdoor bin. She had also purchased deodorized garbage bags, which helped significantly as well, and then had placed air sponges throughout her apartment. Okay, so we're gonna move on, and we're getting through our HOPE acronym, right? We're almost there. We're on the P's. I'm just gonna check the time. Okay. So, pain. So the main etiology of pain specific to malignant wounds really is coming with destruction of the tumor, of the tissue by the tumor. So we have effect on our stretch receptors, there's pressure, there's ischemia, and when wounds are draining, we also have a discharge that is quite caustic and can irritate healthy tissues. Similarly, we also might have some irritation or develop some allergy to adhesives that we're using to keep dressings in place. In addition, we have some mechanical mechanisms of pain with removal of old dressings, which dressing changes can be fairly frequent in this wound population. And then finally, not to be discounted is really the psychological impact that malignant wounds have. And really, this is an outward expression of cancer. And this psychological distress really can have a pretty big impact on the person's physical pain.
We had a question, Melanie.
Mm-hmm. Yeah.
Are there any concerns about debridement in malignant wounds? I often wonder if I may increase bleeding.
Yeah, I think that's a great question. And the short answer is yes to any kind of sharp debridement or mechanical debridement, right? So, and really mechanical debridement in my experience is really quite old school. So yeah, so the debridement you get when you yank off a dressing accidentally, yeah, I'd be a little worried about bleeding in those cases, but I think very rarely are clinicians doing that ever. So it's a good reminder we're going to soak off dressings and stuff. In terms of autolytic debridement, so adding like a gel to the wound to see if we can't remove some of that necrotic and sloughy tissue, that I would be way more comfortable with, because you're not going to have a trauma to the wound that you would get with sharp or mechanical debridement.
Thank you.
You're welcome. So when we're looking at our pain assessment, I always just use a OPQRST UV mnemonic. A good assessment is really required in order to really address the analgesia properly. We're looking at the onset of pain. So when did this pain start? What makes it worse? What brings it on? What can you do to ease the pain. So these are provoking and palliating features. Are there certain positions that work, or does your morphine work to ease the pain? The quality is the patient's description. Is it needles? Is it knives? Is it an ache or a burn or an itching, stinging, crawling pain? Where is the pain? Does it move anywhere else? How long does it last? Is it there all the time? Are there times where you don't have pain? That's an important question too. What is the patient's understanding of the pain? Do they think it means that the wound is infected, or is it healing? Or do they think more pain means that they are dying more quickly? In terms of values, knowing how that pain is impacting the things that are important to them. Does it prevent them from cuddling with their kids or their loved ones? Does it prevent them from getting to work on time? This whole gamut of how pain can really impact our patients.
We had another question.
Yep.
What can we put on healthy tissue to protect from caustic drainage?
Yeah, great question. So again, I'll speak to the community. We have some skin prep, which are barrier wipes, which can be quite helpful. Again, going back to sort of the old school days, a really cheap skin prep is Malox, which you could just get the patient to buy a bottle of Malox and you can put it on the healthy skin, let it dry, and then you could place either a dressing over top, and it tends to be a pretty good skin prep. I think if we're having an abundance of drainage that is really damaging or causing pain in healthy tissue, we'd also be looking at our dressing selection and how can we minimize the exudates as well. And I'm actually going to talk about exudates when we get to E as well, so there might be some tips and tricks in there too.
Great, thank you, Melanie.
You're welcome. Okay, so we're definitely going to need to evaluate systemic analgesia. Many times in the case of advanced cancers, the individuals will have a baseline level of pain in addition to the pain of the wound. Systemic analgesia can also help us to manage other symptoms that may be present. A good example would be treatment of pain and dyspnea with a systemic opioid. So we might look to consider a systemic analgesia if we're not managing the person's pain with either local or topical applications as well. Of course, with systemic analgesia, we will be cognizant of systemic side effects and ensure that we're managing these as well. Local analgesia is a nice option if pain is very local to the wound. Topical applications do make PRN dosing difficult though, because it would necessitate removal of that dressing. So a topical analgesia may also be more palatable introduction to medication if people are medication averse or feel that the systemic side effects of analgesia decrease their quality of life. So maybe in an ideal world, there could be consideration of both systemic and local analgesia used in combination. We might even get some opioid sparing effect, whereby the dosing of the systemic or oral medications could be decreased. And perhaps we might even see with local application of analgesia decrease in the amount of incidental pain that's associated with the wound. Topical analgesia most often is in the opioid class. It works on the peripheral receptors of the exposed tissue of the wound. That said, you might also see some central effect, and we would just want to be vigilant to identify any possible systemic side effects that might be coming from that local application. There are some drawbacks to topical opioids, and I think this has contributed to why we don't see a lot of topical opioids being used. Research is very limited still, and our research really does have just small sample sizes, making it difficult to demonstrate benefit of topical analgesia. We rely very heavily on anecdotal and experiential expertise in this area. Similarly, there is really a cost drawback to compounded topical medications. So these medications aren't covered by provincial plans. So often our clients who do not have private medical coverage, these topicals are out of reach financially.
And so someone just asked, what do you use as local analgesia in a wound?
So I'll talk about that right here. And then if there's questions afterwards, we can talk. So these are some compounds that could be used in topical pain management. So the most common opioid compound in the limited literature is morphine. So morphine could be compounded into a hydrogel or crushed. A tablet could be crushed into like a stoma powder to be sprinkled over the wound. These are applied then to the surface of the wound and then covered with the appropriate dressing. Methadone is another medication that could be mixed with a stoma powder or gel as well. And I do believe that in, not in Ontario, but in BC, methadone is covered for compounding in this case. There is a little bit of evidence for the use of cannabis, and we have to be careful not to paint cannabis as a panacea, but in one paper that I did review, topical cannabis was used for pain control with effect, and the drawback though was the time to effect was very variable. So in some cases, the patient had pain decrease of their pain score within 5 minutes, but in other cases it was hours. The other thing that we have seen is ibuprofen impregnated dressings. So it's again a topical application of ibuprofen, and for the sole purpose of management of the pain of the wound. Cost aside, we are fortunate in Ottawa that we have a fair number of reputable compounding pharmacies. So if ever you would be interested in exploring compounds, these pharmacists are so willing to discuss preparations with you and tweak recipes, etc. So if you're in the community or even not in the community but are a prescriber, finding a compounding pharmacist who will give you their email is a very valuable tool. So we know that many individuals with malignant wounds do rank the pain of repeated dressing changes as high on their discomfort list. Dressing selection should take into account mechanical pain, and adequate skin preparation for the ongoing exposure to adhesives will also be helpful. As much as we could, we would want to optimize the wear time of the dressing so that if at all possible, we could minimize how often the dressings get taken on and off. And many times we can make sure that analgesia is administered prior to the dressing change if again, we need that top up of baseline pain control.
Melanie, just one question. Someone asked if it's possible to get a list of those compounding pharmacies.
Yeah, absolutely. I would, yeah, for sure. You know what you could do? You could email Brittany or Carl, and they can link you up with me by email, and I would be really pleased to share a list of pharmacies with you for sure.
Great, thank you.
Or if we have time at the end, I can type some into the chat.
Okay.
Okay, so we'll do a quick case study for pain. Mr. S has an advanced rectal cancer that's been treated with chemo and radiation therapy. He has a diverting colostomy. The tumor has eroded his external sphincter and it is excruciating. It hurts to sit, to walk, and dressing changes are also challenging as the location is difficult to get to. But also it's difficult to rig appropriate dressing that stays in place. So the nurses, the community nurses are booked at 10 o'clock each morning, which is great because he plans his personal care, showering just prior. But over the last few weeks, his pain is starting to increase. So like at 9 a.m., like clockwork, his pain is starting to ramp up. He is on long-acting hydromorphone, and he takes it at 8 in the morning and 8 at night. And he does have a PRN breakthrough medication available. And he says that he saves the breakthrough medication for his dressing changes, and this is effective. He shared one morning that he has to lie down all day in order to be comfortable, and he is losing hope. And he says to you, I think the end is coming. So our plan for Mr. S. I'm looking at that pain that starts to increase prior to the dressing change, and we decide that he needs a little bit more availability and flexibility with his PRN medication. So we increase the availability to Q1H PRN, and he's going to keep track of his use for a few days so we can see when and how he's using that. We agree that he's going to take a dose of his breakthrough medication at 9:30 a.m. no matter what, so that he's ready for his dressing change when the nurse comes at 10. We ask for OT to look at surfaces that could reduce the pain of sitting, and we ask the patient to participate in the dressing changes. So what we're hoping is that he can take the old dressing off in the shower. That might be easier because he's in a little bit more control. Or if there's an easier position for him to get so we can get to the area, we're going to explore that. We also are going to give him a break word so that if he needs a break during that dressing change, he says the word and he gets it. Finally, Mr. S has given us a clue as to what this pain means to him. And I think he gave us that clue when he said the end must be near. So this is a door opening, right, to a conversation. And certainly this conversation can help to explore any anxiety and potentially lead to some good conversations about even end of life planning. So for me, I might say to Mr. K, and I'll quote, I'll pretend I'm talking to him, I'll say, Mr. K, when you say the end must be near, that must be kind of hard for you. Maybe that's something we could talk about. In my experience, this increase in pain does not always mean that a person is dying, but it is hard for us to know timelines exactly. But there are usually some things that we see that can guide us as our patients near the end of life. Is that something we could talk about today? So it's just I know it sounds scripted, but I do say this a lot, and for me to get comfortable with these conversations, I do use little scripts like this. But it's really meant to open the door to the conversation, and maybe by exploring the meaning of that pain, it will actually help decrease his pain as well if there's any little anxiety component attached to it.
There was a question about the case study.
Sure.
Someone said, why wouldn't they increase his hydromorphone cotton so that he's more comfortable throughout the day, as well as increase his PRN?
Yep, I think that's a great question. And so if I, right off the bat, like I think for Mr. K, and he was my patient in the community, he wasn't really using his PRNs. So he would save 1 PRN a day and take it for the dressing changes. We weren't seeing necessarily end of dose failure or anything like that. So initially what we did is we just wanted to loosen him up in terms of using his PRN meds to see where we would get and how much he was needing to be a bit more comfortable. And then the plan was to titrate the hydromorphone content. So good observation. And yeah, you're definitely on the right track.
Great, thanks.
So we were looking at, with any of our interventions, we are looking at reevaluating. So our pre-dosing of our opioid ended up being kind of ineffective. It didn't help reduce the pain associated with his dressing change. So what we did opt to do as well is we opted to trial a small dose of midazolam in place of the opioid, as we were suspecting that the pain was largely mediated by anxiety and fear around that dressing change. Because if you'll recall back at the beginning of the case study, when he took initially when he took that breakthrough, that the pain was well managed, even though his day-to-day was kind of laying in bed all day because he couldn't get comfortable because of that tumor. He did feel an improvement with that. So then we got into this cycle where, like clockwork, starting at 10 o'clock, he was getting into a bit of an anxiety cycle, which really ramped up his pain. So when we switched over to use a small dose of midazolam in place of that opioid, we were able to target the pain a bit better. Having said that, we added in some dexamethasone as an adjuvant for pain control, particularly around that big tumor in his rectal area and invading that sphincter. And again, our combination was effective to manage the anticipatory pain. So in terms of looking at why we opted for continuing to use systemic medications versus topical, it's because that pain was really in anticipation of the dressing change versus pain that lasted afterwards. So I did want to speak very quickly about itch. There's not a lot of research regarding the frequency of pruritus specific to malignant wounds, but it does appear on the malignant wound assessment tool as sort of a question. So we know it's out there. And as a palliative care provider, it is a symptom that I have struggled with to manage. So you can have itching at the site of the wound or in the tissue surrounding the wound. Commonly in palliative care, we also see patterns of paraneoplastic pruritus, more specifically with hematologic cancers. We might also see some neurogenic pruritus and liver disease or kidney disease. Itch is a response to pruritogenic stimuli, and it does travel along a similar pathway to pain to deliver the itch sensation. I think commonly we could also see our dressing selection as a cause of local pruritus, so like a contact dermatitis at the site of adhesives, or allergic dermatitis as a result of common sensitizers. And in this case, treatment might even be as simple as making a change in products that we're using. Cool packs can sometimes be used to temporarily relieve pruritus that is local. And it also might be, you might be able to employ some distraction techniques when the itch comes. So maybe watching some TV during dressing changes, playing music, or keeping the person's hands busy during downtimes, knitting, etc. Sometimes I'll think about risk management with pruritus, so I'm looking at my patient's nails and making sure they're nice and trim. They might have a soft pair of mitts that they can stroke their skin with if they really have that urge to itch. And then I've also had a patient who has widespread pruritus. She uses just a soft bristle brush, which decreases trauma to her skin. In terms of treatment for pruritus, there's certainly a good start might be a topical treatment. And often ingredients that we see or start with would be menthol or camphor, which both have anesthetic properties, but aren't necessarily going to be appropriate for application to a wound. So for example, someone who has a neurogenic pruritus, they could use this if it's really distributed in a local area, or similar for hematologic skin manifestations. Typically, the menthol and camphor is compounded into a cream or base of choice. Antihistamines can also be compounded fairly readily into creams and topical steroids. Limitations of topical treatment of pruritus is that the itch really does need to be focused. And if someone has a head to toe itch, it's really not going to do the trick to have head to toe topical, right? So we have to look at the practical side of this as well. This is a fairly common anti-itch formula, and this is actually from the Ontario Renal Network. So it's a good cream for renal itch. We commonly will use systemic therapies for widespread pruritus. And again, pruritus will also, is also widespread pruritus that we would see as a result of hematologic cancers and myeloproliferative disorders. Similarly, for malignant wounds that are pruritic, and it may not be feasible to use a topical modality, a systemic, I think, would be very reasonably considered. We see SSRIs used commonly, which act on the serotonergic pathways to reduce itch. Time to effect can be quite quick, which is a nice benefit to this. Antihistamines also can be effective in reducing itch, and selection will be influenced by potential side effects such as sedation or anticholinergic side effects. Mirtazapine also can be an effective choice. It acts on both the serotonergic receptors and some select histamine receptors. And again, we're looking at the side effect profile of mirtazapine, and sometimes there's some wanted or unwanted side effects. Gabapentin has more evidence for use in our renal population with widespread pruritus, but there isn't very much information in the literature with regard to wound pruritus. But in cases where pruritus was refractory or difficult to manage, or maybe in the context of a neuropathic pain, I would probably have a very low threshold to trial gabapentin in this population. My preference for ordering is always to start low and titrate up. So with mirtazapine, I would probably start with 7.5 milligrams at HS. And then if I am getting the benefit, I would titrate up to 15. And then for gabapentin, I would be starting at 100 milligrams by mouth at bedtime, and then assessing benefit from there.
Someone asked, do you ever use, I apologize if I say it incorrectly,
That's okay.
Panictil? It's a barbiturate.
Oh, so no, I haven't. I have seen it in the literature, and I think there's actually a good section on that in the Care Beyond Cure book, which actually has a really great section on pruritus and how to manage pruritus, but I haven't used it myself, no.
Also, just to let you know, Melanie, we're at the 15-minute mark.
Okay, okay. It's good. We'll get there. I promise. Sorry, I'm so
Oh,
sorry.
no, you're doing great. Thanks.
Okay, pruritus. Let's move on. We're on the E's, right? So we're getting there. I promise. It's hope. H-O-P-E. Exudate. The etiology of exudate in non-malignant wounds really is a result of trauma to the wound itself and products of inflammation initially. But in malignant wounds, we'll have a perpetual state of inflammation, and therefore we have a lot of more variability in the exudates. We have very leaky vessels, we have destruction of vessels, a inflammatory state at all times. There may be presence of superficial infection, and then sometimes even we have malignant wounds that are tunneled and fistulaed, which also certainly contributes to exudate. So I want you to know your exudates. These are the 4 most common descriptions that we'll see. We have serous, which is sort of a clear, thin exudate. We have sanguinous, which is that bloody exudate. Purulent, which is really that thick, yellowy green exudate, and then a serosanguinous drainage. Characteristics could also include thick, thin, scant, moderate, large, copious would be ways that we would describe quantities of exudate. And I think the take home really is that oftentimes when we have changes in exudate or in the characteristics and quantity, it does give us some clues, A, on how to manage the wound, and B, what might be going on within that wound bed. Exudates contain proteins, they contain inflammatory products, white blood cells, bacteria. Sometimes they may contain feculent materia in the case of fistula. And they also will contain debris, like in products that we have put into them. So for example, hydrogels. What do exudates do? Well, they can hurt healthy tissue, and they do certainly challenge our dressing selection and the frequency of our dressing changes. So in this picture, we can see that that sort of white, wrinkly skin at the bottom, that's macerated tissue, which is just hyperhydrated with exudate from the wound. In terms of impact on our patients, again, we're seeing a lot of social implications, right? So our patient might feel embarrassed with a big bulky dressing meant to contain all this fluid, or fear that their dressing will leak. It might impact their ability to work or to meet with their family commitments. Vacations can be difficult when you're having a dressing that needs to be changed once or twice a day, right? And also intimacy could be very challenged. And this is at a time where intimacy is already so challenged. So in terms of management of exudates, it is important to remember that sudden changes in quantity and quality of exudate may be an indicator of infection. Which could certainly be treated in order to manage the exudates. In critically colonized wounds, silver honey dressings could be effective. The use of topical antibiotics could be also effective. And in some cases, the use of systemic antibiotics may also help with the management of exudate. For a well-demarcated fungating wound, so a wound that is sort of growing outwards. And fistulas, you could also consider a pouching system. So it's similar to an ostomy appliance. Well, it is an ostomy appliance, just used over top of a wound to collect the drainage. Alginates are highly absorbing dressings, and they could be topped with a foam, which also has a high level of drainage management capabilities. And in some cases, we've actually sprinkled a bit of stoma powder on the bed of the wound just to help soak up some drainage. And a bonus if that stoma powder, if you can get your hands on it, to contain silver, like an Argyll's powder. If available to you, these wounds really do benefit from wound care specialists, wound ostomy nurses, to help with the management, because they really, really are challenging. When I think about outer layers of a dressing, similar to our case with the malodorous wound, you might also add some highly absorptive layers that will both protect clothing and bedding. So I'm thinking of like an incontinence pad. You might use menstrual products. Bamboo can be an excellent absorptive material. And then maybe some washable soaker pads, so that if the wound or the dressing did a leak overnight, for example, it could easily be washed. Often the level of exudates and the ability of the dressing to manage that exudate will determine the frequency of dressing changes. So in this way, it's a great option to involve the patient or caregiver at home in learning how to change at least that outer layer of the dressing, and if only to provide a little bit of freedom and control from this exudate. I'm going to actually skip my case study for this and just wrap up, I think. So I'm going to bring it back to our definition of hope that we had in the beginning of this section of the presentation. And I think what I really would just like you to know is that we don't have to have a cure. We can't have a cure. We don't have to have all the right answers or all the right things at the right time. But I think as healthcare providers, we certainly have to be willing to try. And so we intend to do something. We have to always intend to do something for these patients when they've already lost so much. So for me, that's the crux of providing dignified wound care. So we can assist our persons to set realistic expectations in terms of their healing, and know that even palliating the symptoms is a really great option to have when we're setting goals, right? We're not necessarily healing, but let's offer the alternative, which is our palliative approach to these cases. In the cases where we might experience bleeding, from a light bleeding to a catastrophic bleeding, we do have some viable treatment options. Good planning and development of that emergency plan can really reduce the chances of having a death be traumatic. And for odor, pain, pruritus, and exudate, we also just want to recognize that the impact on our patients is so profound, and using novel approaches, and it's often going to be more than one, and it's going to be trial and error, can provide hope to our patients for a better quality of life. That is it. We just snuck in. Sorry.
All right. Do we have time for a couple questions, or I guess it's 8:25.
I'm easy. Like I'm sorry. Too much talking maybe.
Oh no, you
Sorry.
did really well. Thanks so much. I'm just looking at the comments, and everyone's saying how much they enjoyed it.
Oh, thank you.
I can read out a couple of these comments if you like.
Well, if there's any questions or anything like that, we could I can try and answer them quickly, or yeah. I certainly, Carl, I'll tell you and I'll tell everybody, I really like to talk about, I like to talk about everything. That's partly why it's 8:25, but I would certainly be happy to share my email through you, Carl or Brittany. I didn't put it on my end slide, but yeah, if anybody had additional questions or concerns or questions that I could help with, I'd totally be happy to share my email.
Yeah, I'll send it out to everyone who's registered
Okay.
then.
Thanks.
And just a sample of these comments that are coming in. Stephanie says, I myself could do another 2 hours. I am truly enjoying this. Hard to say goodbye. And Diego says, I'm enjoying every single situation that Melanie is sharing with us. Donna says, thank you. That was fantastic. I want to share it with my team. Carolyn says, amazing, Melanie. Thank you. So knowledgeable. Yeah, there's about 15 more of those.
Aw, thank you.
Yeah.
You know, this could be like, and truly, like, I think I'm not an expert in wound care. We have so many amazing experts, and this could be a whole conference, to be honest. So I think we're just scratching the surface, and there's so much interesting material out there and interesting professionals working in this area. So I'm sure they would all be happy to talk about wounds, and like I am. So
Yeah.
thank you for all of that.
Yeah, and just so people know, because everyone's been sending questions about this, there'll be a recording of the webinar, and I'll send it out to everyone at least a week after the presentation, a week after today. And I'll send the slide deck out to everyone as well, so you can all review it. And just as a final reminder as well, if you want to receive a certificate of attendance, you have to fill out the post-session survey, which I'll email out with the recording as well. Oh, we have more comments from people coming in. Stephanie says, absolutely fantastic presentation. Touched all relevant components. Enjoyed so much. And Robert says, wonderful presentation and content. From Mary Lou.
Thank you.
All right. And Mary says, thank you for sharing your passion and compassion. The people you care for are blessed.
Aw, thank you.
Working Red says, thanks, Melanie.
I talk to them a lot too. They probably are happy to get rid of me sometimes.
No.
No, thank you. I really appreciate it. And I appreciate everybody taking the time. Thank you.
Mm-hmm. All right. Well, I guess we'll wrap up then. And yeah, thanks so much,
Great.
Melanie, and everyone.
Thank you.
Out, and
Awesome.
We'll see you next month.
Sounds good.
Perfect. Thanks so much, everyone.
Take care. Good night.
Yeah, bye.